Good morning, everybody. We'll be starting in few minutes. Thank you for joining us on Sunday morning. Dr. Digvijay is joining us shortly in 1 or 2 minutes. Good
Uh,
morning, Dr. Digvijay. Are you there?
yes, I have just issues with
Hello.
login. I'm just trying to share. So have you
Okay.
enabled the shared option, ma'am? Just a minute. I'm just sharing my PowerPoint.
You can share.
Yeah. Okay. Just a minute.
Okay,
Just
so just a brief introduction. Good morning, everybody. I'm Dr. Gayatri Ekbote, and today me and my colleague Dr. Deepak Malgutte will be introducing you to our today's speaker. So Vikram Londe sir is busy today, so we'll be taking over for today's meeting. So today, Dr. Digvijay Ekbote, who is a consultant rheumatologist at Pune, he's done his MBBS, then DNB medicine, and after that he has done DM in clinical immunology and rheumatology from KGMC Lucknow. After that, he's also done DNB in rheumatology. So currently, he is working as a consultant rheumatologist at Ekbote Hospital, Shivajinagar, Pune, and he's also a consultant at Dr. D.Y. Patil Medical College, Pimpri Chinchwad, Pune. He is also mentor to fellows for rheumatology at D.Y. Patil College, Pune. So we'll be discussing complex topic of osteoporosis and soft tissue rheumatism. And I know this is our we see such patients in our day-to-day practice, and this is really important topic for everybody. I hope you all will like it and you all be able to learn it. And at the end of the session or during the session, whichever questions you have, you can put them in chat box and we'll be taking them one by one. Thank you so much. So Dr. Digvijay, over to you. Please carry on.
ma'am, can you see my slides?
Yeah, yeah, we can. I can.
Okay. Just a minute.
You can quickly run a slide. I can see your slides.
Yeah. So today we will be discussing about osteoporosis and soft tissue rheumatism. I have done this detailed presentation of osteoporosis rather than the treatment of osteoporosis and diagnosing it. It is very important. So let's go through some key facts about osteoporosis. Osteoporosis is a condition which is characterized by low bone mass and microarchitectural deterioration of bone tissue, and with consequent increase in bone fragility and susceptibility to fracture. In India, 20% of the Indian women greater than 50 years of age have osteoporosis. Prevalence of osteoporosis in Indian women is up to a range 8 to 62%. And in males also, in different surveys, it is 8 to 24%. and female is to male ratio of osteoporosis is 3 is to 1. So, as you know, urbanization is associated with sedentary lifestyle, increased indoor living, and lower sun exposure. So, there is increased prevalence in urban area rather than rural area. According to surveys, 10 to 15% of the Indians are only aware of this disease. And for the diagnosis, we use the DEXA scan. The DEXA machine is very costly, so there is a lack of facility everywhere. It is just located to the urban areas, and that's what we lack about uniformity of this service everywhere. 20% of the patient with osteoporosis are diagnosed in India and treated, and treatment compliance rate is around 64%. And in India, we follow this guidelines led by ISBMR, Indian Society of Bone Mineral and Research. There are various guidelines like NOC guideline, International Osteoporosis Federation, but to for Indian context, we use these guidelines. This ISBMR mainly consists of endocrinologists, rheumatologists, dietitians, and physicians. It's a group and which has laid down some good guidelines regarding osteoporosis. So these facts, key facts are from the survey of ISBMR. So let's go through the risk factors for osteoporosis. There are non-modifiable risk factors like age, sex, ethnicity, genetics, and peak bone mineral density. Also, there are modifiable risk factors like nutrition, calcium intake, vitamin D intake, lifestyle factors like smoking and medications, and use of medications. We will come to these risk factors later on as we go through the topic. But if you know, smoking is associated with accelerated bone loss. Also, alcohol does that, and low exercise also is associated with low bone mass. Also, it is a known fact that low BMD, low body mass index, low BMI is also associated with lower BMD. And there are certain use of medications like SSRIs, glucocorticoids, and other drugs, aromatase inhibitors, which are associated with the osteoporosis. So, the osteoporosis is classified as primary osteoporosis, which is 95% of the times it is primary osteoporosis. Like there is no particular secondary cause, but there are some secondary causes for osteoporosis. Like this given in the slide, uh, there are certain this thing like immobilization, some malignancy, CKD, celiac disease, liver disease, IBD, autoimmune rheumatic conditions like rheumatoid arthritis, lupus, myositis. Also, there are some genetic disorders like osteogenesis imperfecta and other systemic diseases like COPD, endocrine disorders like Cushing's disease, diabetes. More important nowadays is diabetes. There is more research into diabetes that diabetes is associated with accelerated bone loss. Also, obesity is one of the prevalent causes of osteoporosis. Also, I have discussed regarding drugs like corticosteroids, heparin, anti-epileptic. So these are secondary causes of osteoporosis. We consider secondary causes of osteoporosis when you have a in young age you have a fragility fracture. Okay, so basically osteoporosis is diagnosed on the basis of uh, osteoporosis is diagnosed on the basis of there is a clinical this thing like patient will have a vertebral fracture which is asymptomatic and there is a height loss or osteoporotic fractures may have pain sometimes and it is based on the BMD. BMD is calculated by using a machine known as dual X-ray absorptiometry. So Uh, uh, so what is bone mineral density values? They are called calculated in the grams per centimeter square, and values are further expressed in the standard deviations of unit from the mean BMD value of the reference population. T score, and what is T score and Z score? Now we will go in the concept. T score of an individual is a number of standard deviation of his and her BMD deviates from the mean BMD of 20 to 29-year-old, like young old reference population. And Z score is of an individual is the number of standard deviation of his and her BMD deviates from the mean BMD of same age, gender, and ethnic group and reference population. So in the BMD report, you see Z score and T score. So T score is a mean BMD, which is compared to the young population, and Z score is the at the same counterpart of that patient, the mean BMD is compared. So in extremes of age, like pediatric or geriatric population, you consider you give importance to the Z score rather than T score. So, so what? What are the indications of DEXA, dual X-ray absorptiometry testing? So, women aged greater than 60 years, men greater than 65 years or older, and postmenopausal women younger than 60 years, and men between 50 to 60, considering their risk profile. Also, women in menopausal transition can be considered for this DEXA scan testing. Like they have a low body weight, low trauma fracture, or high risk medications, and individuals who have had a fragility fracture before age 50. What is fragility fracture is, without incident trauma, the patient gets a fracture of spine or a hip. So also individuals with the conditions like diabetes, malabsorption syndrome, like I discussed with secondary causes of osteoporosis, or who is taking more than 5 milligram of prednisone greater than 3 months, and any individual who is being considered for the pharmacology therapy of osteoporosis. So, what are the beyond DEXA definitions? So, this DEXA definition we have considered. There is another definition for the severe osteoporosis, that patient gets a fragility fracture and the BMD is T score is greater than less than 2.5. That is a definition of severe osteoporosis. And there are some beyond DEXA definition. Likewise, sometimes you can't do BMD due to cost constraints, and there is no need of doing BMD in such conditions where patients with hip and spine fragility fracture, the patient with wrist fracture with a low BMD. And also there is a tool which is known as FRAX, fracture risk assessment tool, where you calculate the risk of 10 years risk of fracture of hip and major osteoporotic fracture. It is validated for USA, but India also uses this from the Singapore data. I will come to that FRAX. So, what are the different modalities? We know that DEXA scan, or this DEXA scan is used for the diagnosis of osteoporosis. There are other things like quantitative ultrasonography, which measures the transmission of ultrasound through the limb bones, and the site is at calcaneum. But these are not validated. Like quantitative CT also is there. It can be taken at the hip or spine site, and it measures the volumetric BMD also. And just a minute, I'll just take a volumetric BMD, and it can differentiate between cortical and calcaneal bone, cancellous bone, and it is a better predictor of vertebral fracture risk than DEXA. It is very expensive. It is considered in the research protocol. Other thing is trabecular bone score. Trabecular bone score is a surrogate marker of bone microarchitecture, and it is an independent risk factor from BMD. There can be a FRAX score adjustment which can be adjusted for TBS if available. So let's come to a fracture prediction tools here. So FRAX is a web-based algorithm which I have discussed that it is considered as a treat for the treatment. It can be used to calculate 10-year probability of major osteoporosis fracture, like hip, forearm, pelvis, or humerus of or hip fracture alone. There are other algorithms are also like Newgen algorithm, Garvan fracture calculator, score simplified calculated risk, osteoporosis risk estimation, osteoporosis self-assessment tools for Asians, and Moore's male osteoporosis risk estimation score. Last three, they are considered by ISBMR. Like they will also consider this age of the patient, height, steroid exposure, whether there are secondary causes of osteoporosis, current smoking is there, any estrogen therapy. All those calculators are freely available on the web, so you can go there. But this last three, score, Osta, and Morse, are validated by ISBMR. But the issue with newer prediction tools is uh, it is not taken into consideration while giving a treatment. Unlike FRAX is uniformly validated fracture prediction tool. So now let's go through the clinical risk factors for the osteoporosis. Uh, so first and foremost important risk factor is prevalent fractures. Other than the site is very important. Other than finger, toes, face, or skull, if you get a fracture, humerus fracture of the forearm bones, spine, hip. So this is very important risk factor. Parental history of hip fracture, alcohol use, smoking, low body mass, level of sun exposure, endocrine disorders, hepatic or kidney failure, history of autoimmune rheumatic diseases, medications like anticonvulsants, glucocorticoids, SSRIs, all those, and also metabolic bone diseases like osteomalacia, hypophosphatasia, osteogenesis imperfecta. So these are the clinical risk factors. Uh, then what will you consider in the physical examination? What points are to be considered? Like you take a height measurement. Uh, you know that the first question we ask for the osteoporotic patients is, or even patient complains, their relatives they complain of height loss in patients with osteoporosis. Like if there is a single vertebral fracture, height can reduce by the 4 centimeters. Kyphoscoliosis can be seen in all those metabolic bone disorders like osteomalacia and all those things. Cushingoid features, most commonly, we as a rheumatologist have this iatrogenic Cushing's due to we use a lot of steroids for the or higher doses of steroids for our patients in myositis, vasculitis. So they will have Cushingoid features, and we there will be buffalo hump, moon face, and all those things like easy bruisability that we also think we consider in physical examination. Pointers for metabolic bone disease like kyphoscoliosis, dental problems, some facial dysmorphism, blue sclera in osteoporosis imperfecta that we consider. Also, neuromuscular disorders like Parkinsonism, some history of stroke. These things are very much important in the physical examination because these neuromuscular disorders are further associated with the falls, and then uh, falls can have significant fractures and morbidity. So Likewise, we have gone through the details like how we should diagnose osteoporosis, how clinically and physically we should examine a case of osteoporosis. So what lab tests can be done? For the primary osteoporosis, we just do DEXA scan, calcium, creatinine, and ALP, which is the primary is osteoporosis in the postmenopausal age and males about 65 years of age. Like for secondary osteoporosis, we consider doing all those tests like liver function, kidney function, IPTH, TSH, other things like for the secondary suspected secondary osteoporosis, we consider serum electrophoresis. Like multiple myeloma is a disorder where you get multiple spinal fractures. So I had one patient in the very first years of my residency who just came with multiple vertebral fractures, and what ESR was above 100 and there was anemia, and we and that patient was around 47 years of age. We diagnosed that patient as multiple myeloma, and so these are important points. Also, some celiac disease like malabsorption syndrome, IgA, TTG tests can be done. Other antibody tests are also available for the celiac disease. In male osteoporosis, serum testosterone can be done for hypogonadism. Overnight dexamethasone suppression test can be done for the suspected Cushing syndrome, and diabetes. ISBMR gives importance to diabetes because in the research which is coming, that diabetes is also a very important comorbidity. Also diabetes is associated with accelerated bone loss. That's why the thresholds for diabetic patients have been reduced. I'll come to that slide later on. So uh, So definitely. So now these are the tests which can be done. Now, what are the considerations from the for the treatment basically? So for the treatment consideration, vertebral fracture or non-vertebral fracture, like hip, wrist, and humerus. Individuals whose age is greater than 50 years and T-score is minus 2.5 at femoral neck or lumbar spine measured by DEXA scan. Individuals with osteopenia, uh, 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 and the clinical factors or the FRAX score, based on the hip for the hip fracture probability of fracture greater than 3.5% and the major osteoporosis related fracture greater than 10.5%. And so I discussed with this last point with you that individuals with type 2 diabetes mellitus intervention threshold should be increased to T-score minus 2 at the femoral neck or total hip or lumbar spine measured by DEXA. So any patient with diabetes having T-score less than point minus 2 should be considered for treatment of osteoporosis. When patients which have a osteopenia like this, you consider this point 3. When there is osteopenia, T-score between minus 1 and 2.5 at the femoral neck or lumbar spine, or there with clinical risk factors, you use a FRAX tool. FRAX tool consists of all those parameters like they consider age, sex of the patient, there are comorbidities or not, then patient is smoking or not, alcohol, and parent fracture risk. So there is a calculator which you can Google it and just see the parameters over there, and you just put the values. But the limitation of FRAX that it considers only femoral BMD. It doesn't consider spinal BMD in that regard. Also, this is from the Indian guidelines. Other US guidelines, they suggest treatment for the major osteoporosis fracture when the risk is beyond 20%. So in India, we have reduced the risk because India has more prevalence of osteoporosis. and fracture. So the risk has come down to measure osteoporosis related fracture greater than 10.5 based on Frax tool. We consider treatment. So now uh, we know how to diagnose and whom to treat. Now there are certain principles of treatment of osteoporosis. So these are some principles that vitamin D, there is a sufficient level which up to 20 nanogram per ml can be sufficient, but higher levels would be ideal. Also, you can supplement with vitamin D if needed. 1000 to 2000 international unit daily maintenance therapy is required. This is a daily maintenance therapy. And if there is a deficiency, you treat either with oral therapy, like any vitamin D brand, which can come 60 K international unit once a week for at least 8 weeks. Also, you can consider if there are some oral absorption issue, like in celiac disease, you can consider giving intramuscular injections of vitamin D, 6 lakh international unit every 6 months. And in as I discussed this, obesity, older individuals, diabetes, they need much more higher doses of vitamin D. There are needed. And certain counseling is required, like a dietary intake of calcium should be there with the along with the supplements should be at least 1000 milligram per day for women above 50 years. Also counsel patients to limit alcohol intake no more than two per day. Also to ask them to stop smoking because these factors are associated with increased bone loss, and bone loss is accelerated by the alcohol and smoking. Also, active, healthy lifestyle, weight bearing, and balance exercises are necessary because prolonged immobilization, sedentary lifestyle can have osteoclastic action on your bone, and there is increased bone resorption. Also, provide counseling on reducing the risk of falls, like particularly among older individuals, like their caregivers. You also tell them to wear some hip pad, like insulate hip pads, like we for the protection of fractures. Also, lighting in their rooms should be ideal. Also, the thing which is to be considered is like in to prevent their bathroom falls, all those things to be considered. uh, if you have you may have this question ki which dietary sources of calcium should be considered in this osteoporotic patients, like in dairy products, they do have a lot of calcium. Also, ragi will have a lot of calcium also, and white sesame, uh, 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 like white till, which is there, which can have a lot of calcium. Also, supplementation of calcium, calcium carbonate versus calcium citrate and other salts. The thing about calcium carbonate is it can cause some bloating and indigestion in certain individual, but it is very cheap. While calcium citrate is bit costly, but it is devoid of such gastric side effects. Also, there are some newer supplementation like calcium aspartate, calcium aspartate with isoflavonoids, which can increase further calcium absorption. But that is the difference between calcium carbonate and calcium citrate. So, what are the drugs available for the treatment of osteoporosis? We have whole battery of anabolic drugs and anti-resorptive drugs. And anabolic drugs what they just act on osteoblasts, and they increase the bone formation. So these are known as anabolic drug. So PTH, romosozumab, abolaperatide, these are the drugs. In India, we have PTH and romosozumab available. Romosozumab has just been available. Romosozumab is anti-sclerostin antibody, which is available subcute formulation. It is given once a month dose, and it is very costly. There are some black box warning regarding romosozumab and its cardiac risk factors, cardiac side effects like cardiovascular diseases. There is a black box warning. PTH, PTH can is coming since many years in the market, and there is teriparatide which is available in the market, which is anabolic agent, and it is coming in the pen form like insulin. There are 30 doses in each pen, uh, and once a day the dose is about 20 microgram per day. So, PTH you can give it up to 2 years, and then you can consider anti-resorptive agents after that. So there are anti-resorptive agents which can reduce the bone loss. So bisphosphonates, as you know, alendronate, zoledronate, residronate, ibandronate, all those drugs, newer drugs like denosumab, which is antibody against RANKL, other drugs which are not available, like Catib and sarcatinib. So, few points regarding bisphosphonates. Bisphosphonates are nitrogen containing and non-nitrogen containing. Nitrogen containing bisphosphonates we routinely use, like this is palmidronate, alendronate, all those, and non-nitrogen containing bisphosphonates were previously used. So, bisphosphonates can be given orally, like alendronate can be given once a week, abandronate can be given once a month, and as you know, uh, zolidronate is available uh, for once a year. Take a minute. Zolidronate is available for once a year formulation. Denosumab is an antibody against rank L, which is given every 6 monthly subcute. And But the denosumab should be given at that time only. Otherwise, it effects weans off, and can patient can have a vertebral fracture if that rebound vertebral fracture if denosumab is not given in that particular time frame. So, uh, so what is the mechanism of action of bisphosphonates? This is very important slide, but just consider one point that it can cause some osteoclast. It is an anti-resorptive agent, so that these bisphosphonates they just inhibit this enzyme FDPS, and uh, there is prenylation of small GTPase, and there is osteoclastic morphogenic changes, some cytoskeletal arrangement. If one line, if you have to summarize this mechanism of action of bisphosphonate in one line, that it can inhibit some enzymes and can cause osteoclast apoptosis. So there is no bone resorption. Also, this slide is considering the action of PTH. PTH acts on both uh, uh, this anabolic pathway and catabolic pathway, but intermittent PTH exposure is associated with increased bone formation, acting on the osteoblast progenitor. So we know about the drugs now. We know about some mechanism of action of these drugs, and so we will go. What are the recommendations according to ISBMR? So according to ISBMR, there are few recommendations for the first line therapy for individuals with prevalent vertebral fracture. Always teriparatide is given a first choice. Teriparatide is anabolic agent of choice, which can be continued for 24 months, and then you can give anti-resorptive therapy. Teriparatide uh, cannot be given beyond that period because there were some reports of development of sarcoma, osteosarcoma in individuals who were given beyond 24 months. Also, but the teriparatide comes with a cost issue, and there is a cumbersome administration of subcutaneous injection daily for the patient that is quite troublesome for the patient. But we should always uh, give from the medical legal point of view, we should always give a choice of teriparatide first. Also, second choice is intravenous zolitronate, which can come in a 4 mg or 5 mg formulation, which can be a pre-filled bottle, which is there, or denosumab. Denosumab is given subcute. This is also an effective option, and there are some there are some problems with discontinuation of denosumab. So zoledronate, due to its ease of administration, once a year administration, it is preferred usually for the initial therapy for 3 to 5 years. Oral bisphosphonates can be used if patient wants to avoid injectable therapies. Like patient will say, Ki, I don't want injectable, then you can give a choice of alendronate and or ibandronate. But the thing is, with ibandronate, there is issue. Ibandronate can be given once a month, 150 milligram of tablet. There is no risk of reduction, no much risk of reduction in vertebral fractures. Alendronate is better in that regard, but then the problem is with alendronate that it should be taken once a week. And there are certain precautions while taking this oral bisphosphonates, like patient should uh, be sitting or walking around or standing. Patients should not sleep if once they take alendronate or oral bisphosphonate, whichever is there, because it can cause severe pill esophagitis, and there are some other side effects also. But for when patient takes this bisphosphonate, ask them to consume with lot of water, like 200 ml of water, and ask them to either sit, stand, or walk after 1 hour of taking this oral bisphosphonate. And that's why the ease of administration of zoledronate is there. That's why zoledronate is now much more preferred. Alendronate is rarely used in practice nowadays. So for the hip fracture, first choice is IVZA. It is recommended that hospitalized or post-surgical patients with hip fracture can be given IVZA before discharge from the hospital. Once they develop this thing, fracture, you can give IV zolitronate in 2 weeks. There is no active fracture is not a contraindication for anti-osteoporotic therapy. That is a very important point to be remember. And those patients who do not want other this ZA or reaction to zolidronate or bisphosphonate can be offered denosumab. And there is limited data about first line fracture, first line therapy of hip fracture in about PTH. And so, first line therapy for the high risk individuals without prevalent fracture. There is no fracture, but the patient has risk. So, like T score is less than minus 2.5, parent history of fracture. These are the high risk individuals. Also, patients on various drugs like glucocorticoids. So, bisphosphonates are the choice. Alendronate, residronate, or annual ZA are effective. Denosumab can be given when patient wants to avoid bisphosphonate or reaction to bisphosphonate. Yeah, this point is again important that teriparatide can be considered for some with very low BMD, T score minus 3.5, with a high risk of vertebral fracture. Like we see a BMD report and patients have T score of minus 3.5, less than minus 3.5. We always should give choice of teriparatide first. And I have discussed this point, like risk of rebound fractures is increased if subsequent doses of denosumab are not administered in that time frame. If you are giving denosumab, ask patient to be very much compliant with denosumab and at a given time. Otherwise, it will have a, rebound vertebral fracture due to weaning of effect of denosumab. There are certain considerations while giving treatment for the osteoporosis and in CKD and those on hemodialysis. Denosumab is a favored drug because it is not cleared by kidneys, therefore can be used in patients. Because the bisphosphonates are contraindicated in CKD stage 4 or 5. When there is EGFR less than 30, you should avoid bisphosphonate. Whenever patient comes to you, just calculate his or her EGFR for the osteoporosis therapy. Also, risk of hypocalcemia is high in denosumab therapy, especially patients in stage 4 disease. And optimal calcium intake and vitamin D status should be assured before starting it. Even in a normal patients, always assure that patient's calcium is normal and vitamin D status is normal, because what happens is these drugs can have hypocalcemia and patient will have a troublesome side effects due to hypocalcemia. So in CKD you use calcitriol BioD3, that is a brand name, but calcitriol daily rather than using a normal routine cholecalciferol. So now we have considered this recommendations. Now, how do you monitor a therapy based on DEXA scan? In Indian scenario, we repeat DEXA every 1 to 2 years, uh, and an increase in BMD about least significant change, above the least significant change with treatment is good and associated with greater reduction in fracture risk than a stable BMD. So our this thing is target in osteoporosis is increased BMD from just above 5% will also do. Stable BMD on treatment is also an acceptable endpoint. Like it should not reduce. This BMD value, like T score is at baseline, it is minus 3.8. It should be increased to at least minus 3.3 or minus 3.2, but it should not go beyond that, like minus 4, minus 4.2. So also stable BMD is also acceptable endpoint. Then what is a treatment failure? Like loss of BMD beyond, like there is one patient who has baseline BMD minus 3.5 and the loss of BMD occurs further, like after 2 years or 1 year, his BMD score T score shows minus 4 uh, uh, after 2 years. So, and patient gets fractures, two or more fractures, especially vertebral fractures while on therapy. In those cases, just first of all, don't jump to a conclusion. First of all, consider there is compliance, improper dosing, vitamin D deficiency, other causes like secondary osteoporosis, celiac disease, multiple myeloma, uh, endocrinopathies, thyrotoxicosis, other states should be considered. And so this is based on monitoring based therapy, the therapy based on DEXA scan. What is the monitoring of therapy based on bone turnover markers? There are certain bone turnover markers. They reflect underlying bone turnover status and they are dynamic parameters. They can reflect a short-term or acute changes in the bone that are often missed by BMD. So short-term monitoring, like if you want to if you want to confirm patient's compliance or adherence to the treatment or the response, you just do bone turnover markers. These are not very much costly nowadays. CTX is available, serum type 1 collagen telopeptide and serum pro collagen type 1 propeptide. These are available and they should be done at the baseline. 3 months, 6 months, and 12 months after starting a therapy. Uh, at least decrease in CTX by 30% or at least by 100 nanogram per liter from the pre-treatment value is expected in a patient on osteoporotic therapy. And the PNP, a threshold of greater than 20% or 10 microgram from the baseline is considered to be significant. So this is based on bone turnover markers. I think this is complicated for you, but you just remember about the enzymes and monitoring on a DEXA therapy. So there is a concept of drug holiday. What is drug holiday? Bisphosphonates, as you know, zoledronate, alendronate, they can cause a rare side effect due to uh, persistent remodeling of the bone which is there on the therapy. Like they get a fracture which is known as atypical femur fracture without any antecedent trauma on the lateral aspect of the femur, lateral cortex of the femur, which is atypical femur fracture. Though the incidence is very rare, but there is a concept of drug holiday based on that. The patients with high risk, like BMD T score below minus 2.5, 10-year fracture risk more than 3%, or major osteoporotic fracture risk greater than 20%, are not deemed to eligible for drug holiday. Like thing is, subsequently we give the zoledronic acid every year for 3 years and assess if the patient has a high risk of fracture. Fracture risk assessment should be done every year for such patients. And if patient persists to have high risk, then just go ahead with treating those patients continuously with zoledronate or alendronate. And uh, patients who have a low risk, like BMD of T score at hip and spine greater than -1, 10-year fracture risk is reduced, or moderate risk, uh, they can be considered for drug holiday, because in those patients there can be a risk of this atypical femur fracture which is there. So drug holiday, you stop therapy for 1 or 2 years and then restart it, like that, like you do. Basically, the various trials have been done in evidence-based medicine, and they have assessed their outcomes. So even bisphosphonate, for that matter, even denosumab therapy, there are patients who are taking it for more than 10 years. So it is quite long-term safety is quite established for all the therapies. Uh, Only teriparatide is given for 2 years, then should be should be replaced with anti-resorptive therapy. So, what is approach to treatment failure? Likewise, in the last slide, we consider that there is loss of BMD. Like BMD is there is a loss of BMD beyond a certain threshold. Also, patient develops some fractures, especially vertebral fractures on the therapy. And we have considered this all the points: low compliance, improper dosing, vitamin D deficiency. So what is your approach? Ensure DEXA has been done at least 1 or 2 years of treatment. We have checked compliance. Secondary causes have been ruled out. Continue for next 1 year and reassess the response. And you can switch. Like if patient is on oral bisphosphonate, gets a treatment failure, consider giving IV bisphosphonate or teriparatide. If patient is on IV bisphosphonate, offer teriparatide. If patient on teriparatide gets those fractures or treatment failure, give bisphosphonate or denosumab. So this is quite simplified. I have tried to simplify the cause, epidemiology, causes, diagnosis, and treatment of osteoporosis. There is much more than that. It is very vast topic to consider. So this is all about osteoporosis. I will not go into details of soft tissue rheumatism right now because paucity of time is there. So you know there are certain soft tissue rheumatisms are there. Like what is soft tissue rheumatism is the points or beyond joints which are affected, like bursae, tendons. There is adhesive capsulitis, epicondylitis, recurrent stenosynovitis. If you remember anatomy first year book, BDC, there while reading anatomy, you have read this in details. Plantar fasciitis, carpal tunnel syndrome, tarsal tunnel syndrome, all those soft tissue rheumatisms are important. So, what is importance of soft tissue rheumatism is these patients are much more common in day-to-day practice. Also, a few patients where their arthritis is in remission, but remission means there is arthritis is controlled, but still patients are getting some pain or any symptoms beyond joints. Always a patient of knee pain comes to you. It is not always arthritis. You will have to examine it. Now, there can be a prepatellar bursitis, there can be infrapatellar bursitis. Likewise, in ankle, there can be tendo-Achilles bursitis. You could have seen olecranon bursitis sometimes. Sometimes there is ischial tuberosity bursitis, which can be there in the patients. And this bursae, sometimes like retrocalcaneal bursa or these conditions, they are very much deep seated. So even and the general approach for this soft tissue rheumatism is you give 2 to 3 weeks of NSAID therapy and just see the treatment response. And if they go away, they go away. Otherwise, they need a local steroid injection. So this is likewise universal approach for this soft tissue rheumatism. You initially give NSAID, and local USG helps you a lot for the diagnosis. It's very non-invasive, cheap method for the diagnosing all the soft tissue rheumatisms. Uh, there can be calcific tendinitis, rotator cuff syndrome, and all those. So, some points regarding frozen shoulder. Frozen shoulder or adhesive capsulitis is characterized by pain and restricted movement of the shoulder, and there is usually absence of intrinsic shoulder disease. What happens in adhesive capsulitis or frozen shoulder? There is fibrosis of this all the periarticular structures in the shoulder, and it can follow bursitis or tendinitis of the shoulder, or may be associated with systemic disorders like COPD, myocardial infarction, diabetes mellitus. This can be there. There is extreme fibrosis of those structures, and it is common in women aged than 50 years old, or you have seen mostly diabetic patients. They do come with frozen shoulder, and it is both active and passive movements are restricted for this in adhesive capsulitis. They routinely the treatment I have discussed is 2 weeks of NSAID therapy, but physiotherapy is cornerstone. Physiotherapy in adhesive capsulitis is very helpful. Like if you do physiotherapy in 2 weeks, patient will get better. Supervised exercises that will also do. Another thing which is considered in this adhesive capsulitis is intra lesional or local hydrotherapy. Like what they do is they give they instill normal saline or distilled water in that particular area, and there is opening of fibrosis, and fibrosis the fibrotic tissue relaxes. That is the thing. Or otherwise you can give local injection of corticosteroid, but all this should be done USG guided. Ultrasound guided is must for this deeper structure, because the anatomy is very important. Recurrent stenosynovitis now. Recurrent stenosynovitis, there is a tenderness of at anatomical snub box. In this condition, there it involves abductor pollicis longus, extensor pollicis brevis, and it can cause these patients will have fibrous sheath along radial styloid process. And Finkelstein's maneuver is done to diagnose the recurrent tenosynovitis. Sometimes you get a patient with wrist pain and you just go on treating. So this patient has a wrist arthritis, but see, examine properly. If there is a tenderness, thickening at anatomical snuff box, then and do this simple maneuver, recurrent tenosynovitis is diagnosed. It can be also readily treatable with local steroids and all those things. Even those things fail, then you just consider doing a local surgical therapy.
Dr. Digvijay, sorry to disturb you, interrupt you in between, but we have only 5 minutes left,
Yeah, yeah,
and
I
we have
have.
many questions. We have many questions, so last 5 minutes are for question and answer. So can we
Okay. So
quickly? Do you have
okay,
many?
there are two slides only. Lat
Okay.
so lateral epicondylitis, tennis elbow at the extensor sheath tendon. We have inflammation. Medial epicondylitis at the flexor origin. There is a granulation tissue. This is known as golfer's elbow. Also, plantar fasciitis, it is common cause of foot pain in adults. Also, over some of the patients with ankylosing spondylitis, there is a pain which originates near the plantar fascia attachment at the medial tuberosity of calcaneus, and diagnosis is done by USG or MRI. uh, First of all, you use NSAIDs, then steroid injection is quite risky because plantar fascia may rupture. And those who are not responding, you can consider fasciotomy. So thanks MRA for giving me opportunity. I have not gone into the details because
Yeah.
osteoporosis was the priority talk for me. Uh, we can consider it later on to discuss soft tissue rheumatism in details with
Hmm.
fibromyalgia sometime.
Okay, so thank you for your lucid talk, and we have got a wonderful audience. We've got close to 100 people joining us today. So I'll just go through questions quickly. So Dr. Shabnam Mulani madam is asking, what is there is one request from the host. Could you please switch on your video if you are comfortable?
Yeah, okay, just a minute.
Yeah. So Dr. Shabnam Mulani ma'am's question is, what is the dose of injection vitamin D in severe deficiency, please?
Is my video visible? Yeah. So
Yeah.
am I visible? Yeah.
Yeah, yeah, you are.
So what is the dose of injection vitamin D in severely deficient patient? So generally that is the 60. Okay, if patient's absorption is good, patient doesn't have diabetes, celiac disease, or that you consider oral therapy, 60 K international units vitamin D orally for 8 weeks. Or you can consider for 12 weeks also. And the target value is around 30 to 40 nanogram of vitamin D.
Okay, got it. Dr. Vijay Kumar sir is asking, USG guided intraarticular corticosteroids (NS) followed by guided and graded physiotherapy has shown remarkable result in ROM in my experience. Unfortunately, this is not practiced widely. Is there any side effect of this? So
No,
he says that intraarticular injection and followed by physiotherapy, they've shown good results in pain and ROM. So,
routinely also, Dr. Vijay Kumar, we use this while even we give corticosteroids, we ask patient to meet physiotherapist. I don't think there is any side effect. Uh, we should even encourage patients to give physiotherapy.
okay. Then Dr. Gauri Afil madam is asking, please give more details. Medication related factors should consider during rehab. For example, impact of corticosteroids on strength or bone health. So that's a very good question actually. So what is your take on rehab when patient is on corticosteroid? Because anyway, they are going to lose their muscle strength and bone health.
Yeah, so strength training is important in such purview. there are sometimes, as I discussed, there are sometimes in vasculitis or myositis, even in lupus nephritis, we give a lot of corticosteroid, that too in a higher dosages. But evident steroid sparing therapy, we just taper down our steroids gradually. So, in general, strength training is very much important, other than doing aerobic exercises. And
Okay.
also, yeah, medication related more than corticosteroids, as I discussed. Heparin is one of the drug. SSRIs, like for depression, we use escitalopram, other factors, aromatase inhibitors, cancer chemotherapy drugs. They also have considerable bone loss. These patients on those therapy, so that should be also considered.
Okay. So the next question is by Dr. Raj. When do we start screening young patient diagnosed with CKD for osteoporosis? Is DEXA recommended at all? And how do we balance with risk of adynamic bone disease?
Yeah, any patient with CKD which is diagnosed, you just do a DEXA scan in all those patients. Like CKD stage 3, beyond, you should do all the patients DEXA scan. Also, yeah, sometimes you take, there is this CKD dynamic bone disease is there. Sometimes there are a few endocrine society guidelines that they consider that you take a biopsy from the iliac bone and and see whether there is a decalcification of bone or not, and then you start treating it.
Okay. So last question. This is the last question of the day. Dr. Rashmi is asking, any portable instrument for screening of BMD which can be used in OPD?
Yeah, so I discussed that there is a portable instrument of BMD. It quantifies the BMD at calcanium, but ma'am, it is not validated and not useful, because those sites are this that site is also not important, and that is also not considered in any of the guidelines. So this is just for camp and all those, they use that, but this is not at all useful.
Okay, that's for the day, Dr. Digvijay. Thank you so much for giving us the beautiful insight on osteoporosis mainly and on soft tissue rheumatism. Thank you, audience. Thank you, wonderful audience, for joining us on Sunday morning. I hope this was all useful, and the recording will be available on MRA website as well. Thank you so much. So I'm closing the session today.
Thank you.
Yes,
Thank
thank
you.
you.